The takeaway is supported by Progressive. Are you thinking more about how to tighten up your budget these days? Drivers who save by switching to Progressive save over $700 on average, and customers can qualify for an average of 6 discounts when they sign up. A little off your rate each month goes a long way. Get a quote today at progressive.com. Progressive Casualty Insurance Company and Affiliates. National annual average insurance savings by new customers surveyed who saved with Progressive between June 2020 and May 2021. Potential savings will vary. Discounts vary and are not available in all states and situations.
New CDC data show that maternal mortality for Black women and Latinas increased sharply during the first year of the pandemic. But these data reported nothing about pregnancy-related deaths for Native and Indigenous women, despite previous studies indicating that these communities labor with substantially higher rates of maternal mortality. It's part of a troubling standard practice of many quantitative researchers. But this week, Professor Monica McLemore told us there is a better way.
Native Indigenous people are traditionally and historically excluded because of what I think is a poor scientific excuse, that their numbers are too small to be reported, especially being a laboratory scientist and knowing that we could account for small numbers. I mean, when we have genome projects, we will have an N of one, right? A sample size of one person, but we'll look at 1,000 genes, and we figured out statistical methods to be able to account for that. So I don't understand why we keep arguing that the numbers of Native Indigenous individuals, especially pregnant people, are too small for us to do any kind of analytics in terms of understanding just the basic counts.
For more on this, I'm joined now by Abigail Echohawk, who's Executive Vice President at the Seattle Indian Health Board and Director of the Urban Indian Health Institute, also an enrolled citizen of the Pawnee Nation of Oklahoma. Thanks so much for being here, Abigail.
Thanks for having me.
And also with us is Caroline Davis, a research associate working with tribal nations and tribal organizations and a member of Navajo Nation. Great to have you here, Caroline.
Thank you. I'm happy to be here.
Caroline, I want to start with you. We were a little stunned when we saw just the erasure in the CDC data that we'd been mining and trying to think through. But why are Indigenous women so frequently left out of data on maternal mortality?
So there's definitely a lot of factors that contribute to that. And, the beginning of the pandemic kind of compounded on top of those things. It's kind of this basic how we continue to be invisible as Indigenous people. And we're, the absence of us in data, accurate media images, and historical and contemporary awareness. And this is perpetuated by federal and state agencies because of what was shared just a little earlier, that there's the excuse that our population is too small. There are other issues on top of that, including, issues with at the point of data collection. There are many cases where Indigenous women are seeking care and they purposely don't report that they're Native American because they know the history of these systems that they're in, and that it's likely that they're going to receive a better standard of care if they're not identifying as being Native American.
Okay, I want to pause right there and have you walk through that just a little bit more, Caroline, so that for our listeners who may not have that same awareness, who may not know that history. So walk me through that history just a bit, especially related to pregnancy care.
There is a lot of knowledge that has been lost because of this Western approach that we take to medicine. And a lot of those things are either in direct conflict or just not complementary at all to what are traditional practices of a lot of tribal nations. For instance, like the midwifery model. That probably more aligns with how tribal nations traditionally would deliver prenatal care to women when they were pregnant. But this is something that even is newer in kind of accepting that midwifery model. I think it was a lot in the maybe the 60s and 70s, where that was kind of shifting away from that being a legitimate means of receiving prenatal care because it was so different from the Western model. And a lot of, I think that's still true today because there's this idea that pregnancy and giving birth is a medical condition. And a lot of Indigenous, the values of Indigenous people, they don't look at it like it's a sickness. It's not a medical condition.
Abigail, help us to understand some of the direct harms that result from this kind of data erasure, this quantitative erasure of Indigenous birthing people.
We continue to see a lack of data on American Indians and Alaska Natives, not just for birthing people, but generally in the way that data is collected around health outcomes, health disparities, and health resiliencies. As a direct result of that, we find that our treaty and trust responsibilities, the responsibility that the federal government has for the payment of the taking away of our land, the treaties that were signed, is very often determined by the number of tribal members. And so when we don't have this data, that means that very often we're trying to prove to the federal government that we have people who are being affected by health disparities like maternal death, infant death. And when we're not being recorded in that data, that means the resources, the policies, the intervention, the prevention efforts are not being directed in a correct way without this data. I call this data genocide. It is one of the ongoing ways in which we are erased within this American society, and it has to change. We know that we can change the way that data is collected at the point of care, all the way to the way that it's interpreted at places like the CDC. We need to ensure that lazy epidemiology isn't being done. There is small populations data analyses that can take small populations data, like Dr. McLemore said, and do good analysis. My team and I do it every single day. And until we see systematic change, we are continuing to be eliminated in the data, and it is directly harming our people every single day.
So, Caroline, you were talking a bit earlier about practices that don't always show up, for example, in maternal health practices that don't always show up in the ways that, for example, sort of hospitalization, medicalization of pregnancy and childbirth practices do. So talk to me about the work that Indigenous-led organizations are doing to strengthen maternal health and maternal health outcomes.
So there has been quite an influx in the number of organizations that are focused on Indigenous birth workers, whether that's birth centers, organizations that are training doulas, breastfeeding support workers. And the approach that they're taking to this is integrating a lot more of those cultural practices that have kind of been, I don't want to say forgotten, but haven't been used for many, many, many years because of this medicalization of pregnancy. So integrating a lot of those things with some of the birth centers in in First Nations in Canada, and they're starting to be developed here in the United States, that they're looking at it as, creating this space that includes cultural aspects, includes cultural practices in prenatal care and in the actual time of delivering babies, so that they're being brought into this nurturing environment from the time that they're born, versus in a hospital. I don't think we would really categorize hospitals as being kind of a nurturing place. So these birth centers are using a lot of these values and reclaiming this Indigenous knowledge in caring for pregnant women and being able to provide that support once the babies are born. I mean, there's this expectation that's kind of the common, as far as when we're talking about Western and how that's delivered. It's like, you have your baby and you go home with the baby and that's it. You're on your own. And in Indigenous populations, there is definitely this more surrounding support that exists within families. And that's something that has never gone away.
Abigail, as I'm listening to Caroline describe differing approaches, or maybe not even differing, but actually centering approaches where Indigenous healthcare providers are providing care for Indigenous pregnant folk, we've talked about the direct harm that happens from an elimination and an erasure around data. But what are some of the direct benefits that occur when we center, when we do have the data, when we do understand trends, and when we center Indigenous healthcare providers for Indigenous pregnant people?
Yeah, we begin to see outcomes change. At the Seattle Indian Health Board, where a majority of our physicians are Indigenous and people of color who work directly with our traditional Indian medicine folks, who also work with midwives, doulas, people who have been providing that traditional care services for Indigenous peoples for thousands of years. What we find in an integrated system like that are people who birth feel supported. We began to see them breastfeeding and continuing to breastfeeding after birth, which American Indians, Alaska Natives traditionally in Western society have had low rates of breastfeeding. They feel supported. They have opportunities for them and for their children. But what we know is that it is essential for people who birth to be able to make the choice about the kind of births they would like to have. They should have access to their traditional healers, to their midwives, to their doulas. They should have access to a hospital birth that is free of prejudice, racism, and discrimination, if that's what they choose to do. Access to birthing centers. And what we find is they don't have that access. At the Seattle Indian Health Board, our healthy, thriving, birthing people they come into our facility and they know they have come into a place of safety, of wellness, of culture, and of where they are understood and supported as Indigenous birthing people. I would like to see that opportunity for every birthing person in this country. And we need to continue to work to expand, which we do at the Seattle Indian Health Board, with very limited resources, care after birth. It shouldn't stop in supporting the mothers and the babies and the people who birth, 6 weeks, 8 weeks after their babies are born. We need to continue at that for at least 1 year. And we're seeing some expansions in some states in ensuring that that kind of care is compensated, but we're not seeing enough. We need to see a movement in this country of supporting people who birth, not just right after their babies are born, but continuing. And in that, we see outcomes change. We've also focused on bringing back traditional teaching methodologies and safe sleep, like cradle boards, which are a traditional safe sleep that meet every point that is given by the Academy of Pediatrics to support babies in safe sleep to ensure that we don't experience such high rates of sudden infant death syndrome. When we see the revitalizing those cultures and those traditions, we see outcomes change, we see people supported, and we know that our people who birth are moving towards health, wellness, and healing as Indigenous people by Indigenous people.
Abigail, say one last word for us here about solutions, about evidence-based solutions for improving, as you've pointed out here, not only maternal health outcomes, but also health outcomes in first year of life for babies.
We need to recognize that evidence-based solutions have been in our communities for thousands of years. It doesn't have to be Western evidence. And so we need to ensure that these practice-based solutions, one that have been in our families, in our tribes, in our communities, are not stopped by the Western systems of medicine. And they need to be incorporated and valued like we do at my agency. We need to ensure that our folks are supported, that we address the social determinants of health. Can they get to the doctor? Do they have places where they can live and breathe and work and play safely? Are they receiving care that is free of prejudice and discrimination? And we need to ensure that they receive the financial resources along with the facilities that care for them, like my own, the financial resources to do that well and from a cultural perspective. This is where we are seeing change, and it needs to be invested in.
Abigail Echo Hawk is the director of the Urban Indian Health Institute, and Caroline Davis is currently a research associate working with tribal nations and tribal organizations. Thank you both so much.
Thanks for having me.
Thank you.
This week on the New Yorker Radio Hour, an honest conversation about returning to the office.
Forced communal lunches or the strongly suggested communal lunch, open floor plan. Coming back to work is partially about surveillance and micromanagement, and people of color feel that in a different way. Everybody feels it, but people of color feel it in a different way.
That's the New Yorker Radio Hour from WNYC Studios. Listen wherever you get your podcasts.